you're in the right place. This is the Eatfluencer Podcast, and I'm your host, Dr. Maggie Landis. Together, we are going to unpack everything about eating and discover the what, when, and how that will let you lead your best life. This is not your doctor's conversation about nutrition. Today is when you can start to love eating again. Let food be food and you be you. Get ready to get eatfluenced. Hello, everyone, and welcome back to the Eatfluencer Podcast. I'm your host, Dr. Maggie Landis, and I'm glad you've joined me today. You are listening to episode 75. We're already on 75. Weight, stigma at the doctor, hidden in plain sight. That's what we're talking about today. And, this is a topic that is one of my favorite to talk about. I am probably the most passionate about this particular aspect of the weight neutrality, non-diet movement, health at every size movement than I am about just about anything else. Because, first of all, I hear time and time and time again how awful an experience people have at the doctor's office. And to the point where, they don't go back. And the problem is not just that they don't go back to that one provider. The problem is that sometimes the experience of weight stigma is so terrible that they don't go back to get health care anywhere from anyone. And this is not an outlier type event. This is happening in doctors' offices, and I'm saying the word doctor, but this really is sort of any healthcare provider. I'm going to use the word doctor just because that's what's in my mind. But, it's a problem over and over and over in exam rooms, over and over and over, every day, all over the place, with all sorts of patients. We're talking teenagers and children. We're talking adults. We're talking elderly people. We're talking disabled people. We're talking people with significant chronic health conditions, people that need to be in the healthcare system more than anybody else. And sometimes they just can't take it and they leave because the experience of the weight stigma is so negative and so paralyzing that's the end of their healthcare participation. So we're going to talk about today some places in the doctor's office, in the provider's office, where weight stigma is hidden in plain sight. See, the thing is that for me, it's easy to see these things because this is like what I look for. These are the glasses I wear to look at the world now. And so picking out diet culture, picking out weight stigma, picking out fat phobia is like quite easy for me. But if you're not practiced and sort of skilled at that, it's sometimes so obvious, yet so not obvious what's going on right in front of our faces. And I want to pause for just a moment here and mention, first of all, I'm not throwing shade at the providers themselves. We are trained, we meaning health professionals, including doctors, dietitians, physical therapists, mid-level providers, whatever. We're all trained in a exceptionally weight-centered, diet culture influenced model. So I'm not suggesting that these providers are malicious or they're purposely stigmatizing their patients and clients or anything like that. I don't think the people are bad. I think the people just don't know how bad it is, what they were trained to do, and how it is negatively impacting their patients. The problem is not just that it's not a nice feeling and people don't want to come back and they don't give you a good Yelp review or whatever. This is about them having worse outcomes. And clearly, if you leave the health system altogether and you don't go and get checkups and get your blood pressure checked and get your cancer screenings and stuff like that, the probability of something becoming a major problem is higher. But even if you kind of grin and bear it and still intermittently go back, the side effect of a stigmatizing experience in a health setting is increased disordered eating, increased rates of eating disorders, increased depression, anxiety, including body image issues and other kind of psychological comorbidities that can be life-threatening in terms of suicidality. It increases the stress response. So actually the body shaming and sort of weight stigmatizing experience makes people's blood pressures go up. It makes their blood sugars go up. It makes their adrenaline response accelerate. It affects their sleep. It affects their mood. It affects their ability to do physical activity. It affects their pain receptors. It is globally bad. It's not just not nice. It's actually really, really harmful. And this is there's a lot of emerging science that shows how harmful weight stigma is in terms of health outcomes. And it's a challenging thing to study and control for and sort of monitor because, of course, it is so baked in to our practice. It's almost, impossible to have a weight biased free group to study. But there is pretty good information that a lot of the health outcomes we attribute to weight may in fact be largely or completely attributable to weight stigma and other social determinants of health that are not in a person's control. So to say that more simply, us badgering the patients about the weight is worse for them than them carrying weight on their bodies. So I want you to know, first of all, if you're a provider, I feel you. I know you can feel sort of trapped because you probably see how our weight-centered model of care doesn't really work. We've been telling our patients and clients to lose weight and move more and eat healthy and watch their portions and all this sort of stuff for decades. But the truth is, our patients, kind of on a big scale, are less healthy than they were 10 or 20 years ago. And they're not even smaller. Not that shrinking our patients and having them all lose weight is the goal. I don't think that's really a clinical goal at all. But even if that was the goal, even that goal is not working. So we're really beating our heads against the wall, continuing to do the same thing over and over and over, expecting a different result. And it's not going to happen because it doesn't work. Weight is not a behavior. Weight is a product of probably 100 or more sort of independent variables, only a couple of which are within a person's control. I don't know how you really create a percentage for this, but I have read in several places that, probably less than a quarter of the influence on weight is personal health habits like diet and exercise. And meaning that, somewhere between 2/3 and 3/4 of the influence on weight are other factors that we can't control. So, not only does the continuous advice to lose weight coming from a medical professional not help, it actually harms. And I think we have a higher calling and a more elevated level of responsibility to understand these things and talk about these things amongst our professional colleagues and change our practice. We have to do it. It's the right thing to do. It is the most evidence-based thing to do. It is the most ethical thing to do. And that's what I want to do, is change the culture of the health professions and try as very, very best we can to take weight stigma out of our clinical practices. Now, if you are a provider and you're listening to this, I do have a free training that's called 3 Secrets to Fast Track Your Client's Success by Breaking Up with the BMI. And I have that available. There's a link in the show notes here. It's 1 hour of your time, totally free. It is kind of like the first step in unlocking this gate, and I would love to invite you to participate in that if you're a health professional and you're even pre-contemplative curious about a weight-neutral approach to care. Because I'm really determined to change this. I've been a doctor who's practiced in that model, and I know it's challenging to step away from how you were trained to do things, even when how you were trained to do things doesn't appear to be working. It's still like there's a lot of safety in that, going with the flow. But the more and more I learn, we really, as providers, need to have the courage to stand up for what science at this point really defends, instead of just, kind of regurgitating the same information that is now at this point really pretty antiquated. I've also been a patient who has been the recipient of weight stigma. And I'll tell you what, it's not a good feeling. Now, fortunately for me, I kind of can recognize it and call it out for what it is, either actually call it out with my mouth to the provider, or at least as much as it is in my head, I can kind of ignore how it's affecting me and get the healthcare I need and, take the recommendations I want and leave the recommendations I don't and kind of move on with it. But most patients do not have that level of knowledge or experience to do that. So it's really important we take care of the health environment and protect it as a safe space where patients will come, clients and patients will come, they will come back, and they will participate. So for the content of this podcast here, that was like way plenty of an introduction. I've just got a list. I've got a list of 10 things that I thought of where we might just kind of glance past this and not think that it really looks like weight stigma, but it is. And I want to just point them out because I think being aware is useful, and this may also trigger your brain to think of some other practice environments or potholes that look a lot like this, that are places we can address. Either if you're a patient, you can know to anticipate this and navigate this and plan for how you're going to handle it. Or if you're a provider, you can consider changing your practice. So here's the first thing. And this is a story I hear time and time and time again. Doctors will not approve surgery, like knee surgery, hip surgery, back surgery, whatever, until a patient loses a certain amount of weight. But yet they are very quick to refer patients in large bodies for bariatric surgery, which is, basically a procedure where your gastrointestinal system is surgically and permanently changed so that you do not digest and absorb nutrients the way that you're supposed to, and you never will, because they are cutting part of your GI tract out. Now, whether or not surgical procedures are more dangerous in patients at a higher body weight. I've seen some data on that. I don't know that I'm totally sold, but let's just say it is a little more dangerous to do surgery on somebody in a large body. Well, that is why we have a practice of informed consent when we do surgeries or procedures. Because, first of all, we don't ever know the outcome for anybody. But second of all, there are certain patients that it's, more dangerous to operate on. It's more dangerous to operate on a pregnant person. It's more dangerous to operate on somebody with cardiac disease. It's more dangerous to operate and give anesthesia to an elderly person. There's a lot of people that are at higher risk, and large people in large bodies may or may not be in that group. But even if they are, they still should get the option for care. Where the weight stigma is hidden is where nobody even gives them a choice to have their knee replaced or their back surgery or whatever they need. Informed consent. You explain the risks and the benefits, and they decide that they want to assume the risk to get the benefit or not. That's how it works. But so many times people are told, you can't get that until you lose X number of pounds or whatever. But then when they're, asking, well, I've tried this, I've tried dieting, I've tried all these things, and I can't get this weight off, when am I going to be able to do surgery? Then the surgeon will send them to a surgeon for bariatric surgery. Makes no sense, right? So that's an example of where weight stigma is kind of hidden in plain sight. Another example is withholding some care options, quote, until you lose the weight. Okay, so it's like all the different options to take care of a clinical problem are not available to the person in a large body until they lose weight. Like they're being held ransom until you lose weight. And that's really not how it should go. That's very much, kind of goes hand in hand with the next thing I have here, which is giving different advice for thin and fat patients. So patients in large bodies, patients in small bodies with the same exact symptoms, the same exact clinical problem, getting different advice. Well, that we should be treating the problem. I mean, fundamentally treating hypertension, treating migraines, treating, menstrual irregularities, treating pain, whatever it is fundamentally the same in all humans. And when we give, small and large patients different information, particularly when the large patients have the whole kind of compendium of choices withheld, that's weight stigma, hidden in plain sight. All right, another major problem that is there but in disguise is when doctors and health providers make dietary recommendations, recommend calorie restriction, recommend portion restrictions, recommend eliminating food groups without getting any history about what or how much a person eats. Okay? They assume that if a person is in a large body, that is the result of overeating. I'm doing air quotes. Well, we know that's not true. We know that's not true. We know there are people in large bodies that have eating disorders and are dieting and are on extremely restrictive nutrition plans, desperately trying to lose weight. And without getting a history, when the reflex response from the provider is to recommend additional dietary restriction, I mean, honestly, I get so mad about that. I think it's negligent at best. I think it's possibly malpractice, but you won't know if you don't ask. You are responsible for asking. Okay. Now, I don't recommend calorie restriction for anybody anyhow, even if they do say when you get a history that they're eating, thousands and thousands of calories a day. I still don't think health is measured in calories, and I think there's a lot of other ways to learn about nutrition and feed our bodies without counting calories. But a lot of times people will get a diet recommendation or a plan or a tip from their doctor, and they haven't even been asked what they're already doing. They're, when a doctor says you really need to cut down on what you're eating, and let's say the person's already eating, less than 1,000 calories a day on some uber restrictive diet, like that's dangerous. I mean, that's why I say malpractice, because I think it is harming people. I think it's not just kind of intellectually incorrect. I think it's really dangerous. And kind of hand in hand with that is very, very few times, if ever, have I had a person tell me they were screened for an eating disorder, disordered eating or diet behavior, compulsive overexercising. Like, the assumption in the healthcare system is if you're in a large body, you're eating too much and you're not exercising. And if you're in a small body, you have no problem with food or movement or anything like that. That could not be further from the truth. And, that's this course that I've recently released for healthcare professionals to, transform from a weight center to a weight neutral practice. It's called Take Your Practice Off the Charts. One of the entire components is about eating disorder screening, because we have to do it. You're not going to find it if you don't ask. And it is like wildfire out there right now. It's worse than it was even 3 or 4 years ago on account of the isolation and the stress and the changes in our daily routines because of COVID. So we've got to be screening for eating disorders before we tell people what we recommend that they do. And hand in hand with that, we need to be asking about food security and food availability, and do they have, enough food for their family in the household, and where are they able to purchase groceries, and questions like that, because it does not do anybody any good when a doctor, tells somebody, oh, they need to be gluten-free, and here's a list of vegan things you need to try, and, you should have, protein substitutes and all this sort of stuff, which, first of all, is not substantiated to recommend. But, you might be talking to somebody who is buying their groceries with a $20 bill at Dollar General. And the fact that, your recommendation is totally outlandish and not going to be taken, it's probably going to bring on some level of guilt, and you have no idea how that person is going to respond. This whole piece here could really just be fixed, if you're getting the thread here, by good history taking and good communication, good open communication. But in order to have the clients and patients do their end of the communicating with you, you have to establish a safe space in which they are comfortable to do that. And it's required to establish that so that we can deliver the very best, evidence-based care. So, not asking about what somebody's actually eating or how much they're exercising before giving diet and exercise information, no screening for eating disorders. I mean, and this is especially, I'll tell you what, my daughter's a teenager, had to do it recently, a sports physical for high school, and no eating disorder screening on there. None. Zero. Not a single question or checkbox or anything that would even hint about an eating disorder. And do you know how prevalent eating disorders are in high school? girl athletes. Yeah, exactly. So this is a problem. Okay. Here's another thing that's hidden in plain sight. When the provider is giving out information that's not actionable, so non-actionable advice. And here's what I mean by that is when they just tell you over and over, we've heard lose weight, okay? Weight is not an activity. It's not a verb. It's not a to-do list item. So you can't just tell somebody lose weight, all right? They don't do weight. They need to have actionable information about diet, about healthy movement, about hydration, about stress management, about whatever it is you want to talk about, which may or may not, by the way, result in weight loss, but will almost certainly guarantee improvement in health, regardless of that. But we hear that all the time. Lose weight is not an actionable item. But there's also stuff that providers will say, like, manage your blood sugar. Okay, that's very much like lose weight. Like, you don't manage your blood sugar, like sit in the chair and close your eyes and think real hard and like make your blood sugar go down. Okay, manage your blood sugar. Like, what do we do? I mean, we need recommendations. We need actionable things. And so just, telling somebody to lose weight, manage their blood sugar, kind of watch your carbs, or what does that mean? Regulate your metabolism. I've heard that, balance your hormones. I mean, that is just like I'm going to sit here and, communicate telepathically with my pituitary gland and balance my hormones. Like, you don't do those things. There are actionable steps you can take that will change how you absorb carbohydrates in your diet, that will probably, regulate peaks and dips in your blood sugar, stuff like that. We have to give the boots on the ground advice and not this real wishy-washy nebulous thing, because what they're going to do with that non-advice is go to their favorite Dr. Google, and you better believe if you type in, how do I, balance my hormones? How do I manage my sugar? How do I regulate my metabolism? You know that the top 1 to 100,000 hits are going to be diet, culture, propaganda, like just total junk, snake oil garbage. And so we need to protect our patients from that. We're the doctors, we're the healthcare providers. Like, we're not just repeating garbage from the internet. So, keep that in mind and keep your advice tactical. Okay, the next thing is the facility is not prepared for people in all sizes. That is weight stigma, weight bias, kind of silent weight bias, all right? When there's no chairs in the waiting room without arms that will fit a even sort of moderately large person, that is a, read between the lines comment on who is acceptable in this practice and who is welcome here, and what we are prepared to take care of and who we're prepared to take care of. It's kind of like, and I'm not talking, I have sat in some teeny tiny chairs in waiting rooms, all right? And I'm in a larger body, but I am by no means in a super marginalized size. And I've gone to get tests done in radiology or something where they have you change into the hospital gown, and there's like, medium and large hospital gowns, and I need a size bigger than that, and I have to go out of the changing room and go ask, somebody to find one. Like, that is weight bias in a very quiet, sneaky, hidden form. But so think about this, and I've heard people defend this by saying, well, we can't just accommodate everybody. Like, I mean, we need to like have gowns and chairs to accommodate like the 1,400-pound man. I mean, we have to have everything. Well, that's not necessarily true. I mean, that would be great, but I think at a very basic level, we should be able to accommodate, the center 2 or 3 standard deviations of people from like average. Okay. So it's like, for example, the standard door height in like a house, I think is 7 feet. I think kind of a standard door, if you're not in a fancy house where those are really tall, but is like 7 feet. Okay. Is there possibly a person that's over 7 feet that might have to duck in the doorway and be inconvenienced? Probably. But like 99.99% of everybody who buys a house won't have to do that. We don't say that 5'5" is the average height of a adult American woman, and so we make the doorways 5'6" so that they fit, but everybody taller than 5'6" has to duck and squat, because that would be a lot of people. That would be like a large group of people that don't, it wouldn't make any sense, right? Because we want to serve at least the biggest majority that is reasonably possible to serve. But I don't think, having a width of seats on airlines of 16 or 17 inches, of having, metal stools with arms in the waiting room of the doctor's office for somebody, that has to have a 30-inch waist or less to sit in. Like, I just don't think we're even accommodating the average in a normal distribution from, quote, average. I think that's really problematic. And then I can't even emphasize enough centering our patient's experience on the scale, having the scale the first touch point, having the scale be done, having a patient weighed before they've had any screening, any eating disorder screening, any history taking, anything, is really almost criminal. It's not necessary. The information is not necessary, and it is certainly not necessary to be first like that. And without any history, without any context, without talking to the provider, without knowing what the chief complaint is of the day, like, it's just a habit that we have to put the scale first. But I've said many times, if we construct our healthcare interactions as a weight first interaction, it will always be a weight centered interaction. There's just no way around that, because once that is done and it's done first, the rest of the visit will not be the same for the patient. It just won't. And, these are easy fixes. These are really easy fixes. And that's why I, created a course for professionals to show that I'm not talking like renovating office spaces and going to complicated, continuing education and getting more, fancy certificates or degrees, or participating in a really in-depth, advocacy organization or something. I'm just simply talking easy tips, having the right equipment, taking the scale out, doing eating disorder screening, all the really basic, low-hanging fruit stuff that will revolutionize our experiences with patients and clients. We owe it to them. We owe it to them if we are going to practice the top level of evidence-based ethical clinical care. This is what it is. What we were told to do 10 or 20 years ago, or even a year ago, because this garbage, weight bias, fat phobic teaching is still in the curriculum today, right now. And so we've got to change the conversation and change the way we practice. And the benefit is huge. The benefit is huge because we make space for the conversations that we need to be having. We create a safe, trustworthy space where they are welcome and are motivated to share what they really need from us and where they really need our support. We are able to offer recommendations that are actionable, and when you give them something to do that is doable, the chance of them doing it is so much greater. And they won't be lost to follow-up. They won't be sitting in their car crying after the appointment. They won't cancel all of their, future appointments. Like, we'll keep them in the system so that we can do what we do best, which is, supporting patients and identifying and treating disease and, whatever it is in your discipline that you're trained to do. When you get the weight stigma out of the way, you're able to do the thing so much better. So anyway, I hope that this has made sense to you. And if you're a patient, you're not a health professional, you're probably like, yep, I've had that experience. Yep, I've had that experience. I'd love to help you learn to navigate that too. So I have a workshop called Getting Care Out of Your Healthcare, which is a 75-minute training on demand for non-professionals and teaching how to navigate the healthcare setting and how to advocate for yourself, what language to use with providers to get the answers you need. Just sort of a little bit of a, what would we call it? Like, it's like a toolkit to help you out in those challenging situations. And then, of course, as I mentioned, I have a professional training that is 1 hour free training for professionals that are interested in breaking up with a BMI and learning to start adopting a weight-neutral model of practice. And the links for both of those things will be in the show notes. You can click through and take a look at those if you're interested. I appreciate all of you joining me today, and I will talk to you next Wednesday with a new episode of the Eatfluencer podcast. Until then, thank you so much for being here today. If you love what you've learned, follow me on social media at Maggie Landis MD, and you'll never miss a thing. You can also check out my website at maggielandismd.com and sign up to be part of our community of eaters. Thanks again for stopping by. We'll talk again soon.